welcome, welcome. My name is Jessica Kahn. Sorry to be masked. I'm in a clinical space, but welcome to K Club. We appreciate your joining us. I'm here representing the KL2 program with Krista Metz, who's our phenomenal program manager, who keeps us all in line. So welcome to our K Club. K Club is a monthly seminar during which we have discussions about issues of interest, particularly to junior investigators. And today's talk is called Practice-Based Research, Recognizing Opportunities to Engage Community Partners. We often get suggestions for topics, and I believe that this is one of our suggested topics. And we have two fabulous speakers. I'm going to introduce them in just a moment. Krista is going to be monitoring the chat box, and then you will receive an evaluation by email, and I'll ask if you could complete that evaluation because it's very helpful to us in terms of planning future sessions and helpful for the speakers. So our distinguished speakers today are Dr. Sani Regan. She's an assistant professor and research scientist, as well as director of research in family and community medicine at the UC College of Medicine. And her research interests include social gerontology, palliative care, and chronic illnesses. And Dr. Bill Brinkman is director of the Division of General and Community Pediatrics and also the Carl Weil Professor of Pediatrics at Cincinnati Children's Hospital. He is very much involved with the Center for ADHD and the Center for Innovation in Chronic Disease Care, and has directed a community-based research network of pediatricians, and he's also a professor in the UC Department of Pediatrics. So welcome to our speakers. Thank you so much for your time. Thanks to all of you for joining us.
Thank you for introducing us.
Yes, Jessica, thanks for the introduction. I'll kick us off with the learning objectives. So at the conclusion of the session, we hope that participants will be able to describe the community engaged research spectrum, describe the structure of practice-based research networks, and differentiate between projects along the spectrum of engagement that we described. If you can go to the next slide, please. So we wanted to start by just getting having a couple of polling questions to get a sense for who's in the audience today so we can best meet your needs. And we'll, if you could, Chris, if you get us started with the first question. So just curious kind of where you're at, what stage of career you're at in terms of, I know this, you know, we could have folks from fellows to early stage faculty to mid to senior faculty. And others. All right. So it's helpful to see we've got a couple mid to senior faculty, but also looks like
Sorry.
a fellow and early stage faculty. Thank you. And we can go on to the next slide. So this is a depiction of the spectrum of research which NIH currently has on their website. When you Google the translational research spectrum, I think the visuals for this have changed over the years, but this is the latest depiction. And so they kind of depict kind of different realms of research, from basic to preclinical research to clinical research to implementation and public health research. And we thought it would be helpful to get a sense for, you know, kind of where your research, which realms your research is typically in. So we're going to the next polling question. And I guess we could, since folks can do more than one thing, if we get to predominantly, so it looks like predominantly we have clinical research and some public health, it looks like. Great, thank you. And then our final question is, we can pull that up. Just trying to get a sense of your experience with practice-based research. You know, have you not done any studies in practice settings, or have you had at least one study in a single practice, or at least one study involving more than one practice? Okay. All right, that's helpful. Appreciate you taking the time to do that. And we have a small group. So Sony, if you're all right with it, I was going to say, just folks can jump in along the way to ask questions. We want to make sure you guys took the time to join us today. We want to make sure you have your needs met. And so the last just before we get kind of into the bulk of the content, we thought it would also be helpful to kind of get a sense for the type of research that you do. So if you could use, we're going to go to the whiteboard, and if you could just use like a one word to describe the topic of your research, that would be helpful, just to give us a ballpark idea of what folks are focused on.
If you've never used the whiteboard before, there should be something at the top of your screen where it says view options. And then if you click down to annotate, you can draw on the whiteboard. Typically, I use the text because actually drawing is pretty darn difficult.
As cool as this whiteboard is, we've got so few people, we just go around the circle. But thanks those who chimed in with that. Now we got a couple more coming in here, it looks like.
Thank you. This is great.
Yeah, thank you.
Oops. Now tell me what to do, Crystal.
You should be able to go ahead and advance your slides now. Just go ahead and reshare your PowerPoint. And there are a few comments in the chat too. Someone was using their phone and wasn't able to write on the whiteboard, but ADHD and adherence to medication was another comment.
All right. So I can just get back. So when we talk about the spectrum of community engagement, there are kind of three buckets that it typically falls into. So the first is investigator-initiated research, and that's kind of where an academic researcher is interested in a topic, and they come up with the study, they design it, they get the funding for it, they ask the practice or practices if they can collect data there. So it's very much done from the top down, and a lot of times we call that helicopter research, where the people don't really know they're being researched because a lot of times it's some kind of EHR review. There might be an intervention and then another EHR review. So it's looking at usually big data, and a lot of times the staff doesn't know that there's a project going on, and the patients many times do not know there's a project going on. So that's what we consider the investigator-initiated research. So collaborative research also may be carried out in community settings in addition to a practice, and that's going to most likely involve some partners And so you may get a group of practices together and ask the physicians or other healthcare providers topics that they're interested in. And this is kind of how we got going in our first one with the Practice-Based Research Network. Is we had a symposium for practice-based research when it first started. I think it was back in 2010 or something like that. We asked the physicians kind of what their interests were. And for the family and internal med docs, it was primarily at that time opiates and chronic pain. So it was when, you know, opiates were coming under much more scrutiny, patients were having their opiates taken away. And so there was a lot going on. Again, the patients didn't necessarily know that they were in a research project. There was an observation that went on in several different practices, seeing how the physicians were able to communicate this information to patients. And so obviously the physicians knew what was going on. Usually the MAs or nurses knew what was going on, but the patients still didn't really know. And the academic partner was the one who came up with the topic. I mean, the partners came up with the topic, but the academic researcher came up with the study. And then presented the results back to them. So, and then finally, I have to move people. Community-based participatory research, there's much more shared power and control and ownership over the project. And so all partners are typically equitably involved. So a lot of time, like the one I'll present to you today, what's happened is a community advisory board in a neighborhood has gotten together. They've looked at some results from a collaborative research project, and now they're deciding on what kind of project they want to do in their own community, kind of how data will be collected, what the intervention is going to be, and so forth, and then how it'll be presented to the community. So that's more, you know, the academic partner is there to guide and to say, you know, this would be make a good research project, or you may collect data this way. And the community is more the people who are coming together to come up with the actual topic and intervention. So how do we define community? Well, it could be many different things. The communities that are involved typically in practice-based research are both the practices, what we call the Practice-Based Research Network, is the community of primary care practices. So it's the community of the physicians, other providers like APRNs and PAs, and other team members that are part of the clinic. And the one that I described earlier about chronic pain and opiates, that would be a practice-based research network. It took place in several different practices that were part of the network, and the results were presented both individually to each clinic and overall as part of the Cincinnati health system. It can also be a community of patients or families that are cared for in those practices. So for example, our residency has started a patient family advisory council. It includes patients from the clinic, family members from the clinic. It includes the physicians, it includes the staff, the practice manager, and then it's a residency practice, so it includes residents. And they get together once a month. They talk about different issues that are going on in the clinic. We switched to virtual, obviously, this year. But that is really run very much by the patients and the families, as well as the physicians and the staff that are at that practice. And that has expanded now to 3 other patient family advisory councils. Or it can be a population that lives around the community of providers and community of patients. So when we talk about population health, in our perspective, we're looking at the communities around the practices, whether they're patients or not. So that would be also what you could define as community. So the Cincinnati area research and improvement practice-based research network structure looks like this. We were funded by the CCTST Community Engagement Corps. I wasn't the director then, but now I'm the director of the Caring Network. I have an associate director that's also funded by the grant, a small percent, 15%. And then I have a research assistant, and I have a division, so I have several research assistants, but they pay for 50% of a research assistant. And then we're able to go out to practices, and we're able to go out to communities to do research that they are interested in. And then sometimes that funds our time, it funds the research assistants, and so forth. And then here's what the Caring Network looks like. So we're as far north as Trenton, and the Florence one has closed, but it includes several of the UCH primary care practices. It includes the Hawksworth practices, the Christ hospitals. Our residency is located there, so we use that, as well as the FQHCs, 3 of them that are around Cincinnati: Crossroad, Healthcare for the Homeless, and then we're trying to get Equitas on board. All right, Bill.
Thanks, Hani. The CPRG's history goes back to like 1996, when Tom DeWitt and Bob Siegel formed it as a network initially, and it's really kind of evolved over time. Because we only operate 3 practices. Historically, I think when it was formed, we only operated 3 practices. And almost at that time, almost all of the practices in Cincinnati were independently owned. It really was kind of practices and physicians kind of voting with their feet from project to project about what they were interested in participating in. Over the years, just the landscape of primary care has really dramatically changed in a lot of ways, and the interactions that community pediatricians have with the academic health center have fundamentally changed. 18 years ago when I came, vast majority of pediatricians still rounded in the hospital, and now none do. And so the opportunities to kind of have shared interests and know each other's interests well have changed dramatically. In response to this, one of the things that Children's Hospital has done is to create a community physician advisory board, which has now Shelley Vogt as the executive community physician leader, and another 6 pediatricians who are employed by independent practices, who serve to kind of regional representatives for their regions in the kind of primary referral area around children's. And the hospital has kind of seen this as important to try and maintain those relationships with practices and to try and understand how children's can best meet their needs. As a research network, we've tried to leverage this to kind of really understand what are the challenges that folks are experiencing in practice, and how does that intersect with the types of activities that go on with a practice-based research network. Therese Martin also directs physician outreach and engagement. And so in addition to the physicians, there's also another set of kind of practice liaisons that maintain relationships with the practice. So all of these kind of common pieces of infrastructure have been really helpful to both kind of understand like what are the community needs, but then also as specific opportunities come up, like who might be interested, in a project, no matter where along the spectrum that Zoni describes might fall. So just as an example, for an investigator-initiated project, we have an intake process which kind of solicits like the information that a pediatrician in practice would really want to know to help decide, is this something that I would want to do, and would it be feasible to do in my practice? And then we'll bring that sort of information to this group and get their thoughts on it. Oftentimes critiquing and offering suggestions for improving it in terms of increasing the feasibility of a project, but then also kind of helping spread the word and/or connect with folks who might be interested in the topic. So we can go to the next slide. So what we wanted to do with that kind of backdrop of what our kind of structures of our networks look like, and kind of the broader, context of, what the engagement spectrum looks like, we just wanted to kind of share some examples of projects locally that kind of fall in different areas of that spectrum. And I did want to say before I jumped into the first example that while we're kind of coming from the perspective of primary care, and that historically speaking, primary care is where the practice-based network approach really was born. I think it's safe to say there are a number of specialty-based and other practice-based networks now. And seeing Kelly on the call, I know that there's one for developmental and behavioral peds as an example. And so there's a number of approaches to this that are not primary care based and are specialty based. I think it's important to acknowledge that. Because while our examples today are going to be very primary care based, there's also a ton of examples out there that are from different specialties now. So I wanted to share one example to get started of an investigator initiated project. So this came from our team if you go back, from our team in general community pediatrics. We're very focused in our primary care centers on preventative care service delivery. And, we locally, as well as folks nationally, obviously, we're seeing a tremendous impact from COVID-19 on preventative service delivery to children. And this is some of our data from the beginning of the pandemic showing on the left, the percentage of children who received their first mumps, measles, rubella vaccine by 15 months of age, and how it kind of precipitously dropped off early in the pandemic. And then, and then on the right, the percentage of children with their second MMR by 5. And again, kind of the drop off that was seen and expected to continue. And again, this was, early in the pandemic, folks were advised to, cancel their well child visits to avoid potential exposure to COVID, and or reschedule them. And then after that changed and folks were, invited to come back and take care of well child care, folks were really hesitant, understandably so, especially given the rates that we saw in our community and around the country. So we really saw this as something that we were going to need to really aggressively pursue. How are we going to get kids caught up so that we don't have additional health impacts from COVID-19 beyond COVID-19 in terms of under-immunization and outbreaks of other infectious diseases, and or the other types of things that happen at preventative services visits, like screening for developmental delays and other things. So if you could go to the next slide. So this, we really kind of saw a need to improve our outreach to families to try and get them back in and to let them know that it was safe to come back in, and that, we really wanted to help get them caught up. And there's a good body of literature about outreach in general as it relates to immunizations, but this is kind of a unique context within which, if you could go back, unique context within which to apply it. So we wanted to test use of automated messages, so either sending one or two, and layering that on top of either no personal contact attempts or one personal contact attempt. Kind of with the idea that the automated messages are easy and relatively cheap to send, whereas we just didn't even have the personnel to be able to contact everyone. So why not conduct a randomized study to figure out, what the relative yield is on these different methods. The outcome measures that we were interested in were appointment scheduling within 2 weeks, appointment completion within 8 weeks, and then for the MMR vaccination completion within 3 months, kind of acknowledging that there's kind of a range there of when it can still be considered on time. And to Sani's earlier point, I think it's worth acknowledging. So this was definitely initiated at the academic health center, and within the academic health center practices, we have 3 practices and 3 school-based health centers. The 3 practices were the ones who were involved in this, and they care for over 30,000 kids a year. So decent size or decent population of children cared for. But it was academic based and involved myself as well as our kind of director of primary care and one of our nursing clinical managers. And based on how this was approved by the IRB, like there was a waiver of informed consent. So, you know, while we have updated like our clinical teams on the progress and what we're learning, you know, families, you know, weren't aware of, you know, whether they got 1 message or 2 or got a call or not, and that sort of thing, to Sony's earlier point. And so if you can go to the next slide, we are wrapping up this study. Boy, it really just wants us to keep moving. We randomized over 1,300 kids, and you can see the breakdown of the age ranges there. And so because of that lag in assessing the outcome of actual vaccination received, our outcome data will not be complete until the beginning of August. But we're excited to see how that goes. We've already taken some sneak peeks at like appointment scheduling and appointment completion, and it does seem like there's a nice effect there. If you go on to the next slide, the other thing that I think is really interesting about this study and could be informative is, you know, obviously one of the big factors of how successful these interventions are is how receptive to the message are people going to be when they got it. And you can see that we had 4 iterations of our trial. So 4 groups of people were randomized over the course of the last several months. And one of the covariates that we'll examine is the incidence per 100,000 of COVID in the 7-day moving average. So, you know, one might expect that you might be more receptive to coming out and scheduling your appointments if you know, feel like it's safe to leave your house, right? So this is something that we'll examine as a potential mediator of outcome. If you go into the next slide. So I'm going to share one example, and Sonia's going to share one example of a more collaborative examples of research. And I have to say, the example I'm going to share may not be really considered research, but because it's much more in the quality improvement and implementation vein. And increasingly, I feel like over the last, you know, 15 years especially, quality improvement has been a big interest in community practices and among participants, at least in primary care research networks. And so I think this example is relevant. So if we can go into the next slide. So there's a group that's led by Mona Mansour called the Thrive at 5 Collaborative, which is a collection of practices. So all of our children's practices participate in this, but so do the Cincinnati Health Department practices and one of the UC Med Peds practices. And the focus is very much on similar issues around closing care gaps for preventative services across the city of Cincinnati. And when you look at the combination of these practices, it adds up to about 80% of children in Cincinnati who are enrolled in Medicaid. So it starts to get at a population level scale, which, you know, when you talk about improving care, really has a chance to make a profound impact on the health of our children in Cincinnati. If you go to the next slide. And for those who aren't familiar with kind of the learning network approach to things, you know, the key really is having shared outcome measures and being able to look at your data across sites. So this is an example of some of that data. So this is, again, this group is one of the outcomes that they're interested in impacting is the first MMR vaccination prior to turning 15 months, as we were in the last study that I mentioned. And being able to have small multiples like this, where you can look across practices to understand, well, which of the practices are performing really well and what can we learn from them? which of the practices have more room for improvement. But then ultimately, and so having that kind of that backbone to build on, and oftentimes the academic health centers are critical in providing that backbone of data analytics and just displaying the data in meaningful ways to fuel improvement. But then ultimately, the practices themselves are the ones who need to come up with the changes and the things that they want to try and improve their practice. I think the other thing that's important to note about this collaborative, and it's, you know, it is kind of a very collaborative approach, is that their focus is on the population level. So these outcomes are not just the kids who are walking through the door. They're all kids who are attributed to the practice, whether or not they've walked through the door recently. And that's a key difference, I think, that increasingly practices have that population lens as opposed to just a visit-based lens. But I'll stop there and turn it over to Sony for her next case study.
Anyone have any questions? I can't see the chat or the people, but anybody? Okay. So I also will be giving you an example of a collaborative research project. It's a little bit different than Bill's. So again, carried out in the community settings, and it involves different partners in some respects. And this all came from the CCTST Community Engagement Corps, actually. So our project was developing a community-based response to food insecurity in older adults in Walnut Hills. We wrote the grant before COVID and were funded before COVID, but then when the grant started, so did COVID. And so we had to pivot and figure out a way to do this virtually this past year rather than in person. So we wanted to actually, I'm a qualitative researcher, you may have guessed that already, but I'm a qualitative researcher. So I like to talk to people, I like to interview people, I like to do focus groups with people to get different aspects of what's happening. So our residents had been looking at the communities around us, and the residency sits at Christ Hospital in Mount Auburn. So you've got Mount Auburn, and you've got downtown a little bit, and then you've got Walnut Hills sitting right down the street. And many of their patients come from Walnut Hills. And so when the pandemic happened and the places closed down, no longer were they seeing these older adult patients. And Dr. Grancy is a geriatrician, and Dr. Hisao, Cito, Saab, Cockcroft are all residents, and Alam, Idling, and Dion were all students at the time. And so it was a big group of people and that got together to come up with you know, something to do in this community to make a change. So people, when you think about virtual visits, and this may be true for many, they didn't have a lot of access to internet, computers, you know, not even smartphones in some cases, because these are older adults. So they're having visits on the phone, basically, which is, you know, you're not getting any real vitals from the person. Really, it's just an interview with the person to ask how things are going, what's the problem, trying to diagnose, and, you know, in some cases providing prescriptions or, you know, other things. But it's all being done by phone rather than actually even seeing a person in many cases. And so the food issue came about from actually the Walnut Hills Redevelopment Foundation. So they have taken Walnut Hills, they've taken it upon themselves to figure out a way to provide food to Walnut Hills basically after the Kroger shut down. So there were academic partners, there are community partners because they have a community advisory board that was also interested, the CCTST, the Christ Hospital, and then the Walnut Hills community. So this is Walnut Hills, the neighborhood. So Mount Auburn is where our residency is. Walnut Hills butts up against it. The yellow triangle is where the Kroger used to be. The red star is where it is now, right in front of the university. And so obviously Kroger was not making a lot of money in Walnut Hills. There was more crime in Walnut Hills, and moving it down to the university, suddenly, you know, they had a lot more people with a lot more money who could shop there than was true in Walnut Hills. So they moved the Kroger 1.3 miles down the road, as I said, more to Corryville and Clifton than Walnut Hills. But for older adults, that became a huge issue because many of them didn't drive, owned cars. They would have to take the bus. I would watch people walk, you know, with their bags of groceries, or they would carry those carts down McMillan after they had been shopping. So this is what the Walnut Hills Food Desert looks like today. The Kroger is just empty. The parking lot is empty. And so one of the buildings of older adults that we had in our study sits right here. Whoops, sorry. The little red building over here in the corner, and that's the Alexandra. It sits on the corner of Taft and Gilbert, if you are familiar. So I made a little map of Walnut Hills. I used to live there, which is why it says 7 minutes to work if you see that little thing. But here was the Alexandra. Here was the Kroger. And the other apartment building was the Alms, which has a lot of older adults, but also a lot of patients with community members with disabilities. So when Kroger moved out, when we did our survey, we asked them, one of the first questions was, so where do you grocery shop now? Well, those who had cars were able to get to Kroger, but they found it really expensive. So they were going to other Krogers. And then they said, primarily, they're getting their food from Dollar General, which sits right in the middle here. They moved in probably a year before Kroger closed. And if you've ever been in a Dollar General, I would not call the food healthy. It's canned, it's, you know, refrigerated bologna, high fat and high sugar types of foods that are available. They would go to Wendy's, they'd go to McDonald's, they'd go to Taco Casa, and Parkside Cafe, which is also one of my favorites. But this is where they were getting their food. It was takeout, and in many cases, Dollar General or United Dairy Farmers, rather than at an actual grocery store. So the Walnut Hills Redevelopment Foundation obviously was extremely concerned about this and hired a food coordinator who then went to the CCTST and took their how do we say it? Bill, you're going to have to help me. It's the Leadership Institute, Community Leadership Institute classes, and graduated from the CLI and received a small amount of money to look into his interest, which was doing a community needs assessment in Walnut Hills to figure out what kind of population we were actually looking at. And so then Dr. Gronsi got involved because she also lives in Walnut Hills. And she also, with myself and two of the residents, wrote a grant to the CCTST, got another $15,000 to be able to have a much broader picture of what was going on in the neighborhood. So you are looking at people with a low socioeconomic status. Their neighborhood Kroger had closed, they had limited transportation. And then there was the challenge of COVID-19. So they did have a food stand that the Walnut Hills Redevelopment Foundation manned every Friday for a couple of hours that had fresh fruits and vegetables. They started planting gardens, and I'll show you a picture. But so our methods, we did get IRB approval to do this. The participants were recruited primarily from the Alexandra and the Alms. They were adults 55 and older who were low income and or adults who were disabled. So all the people, whether they were disabled or not, ended up being 55 or older. There were also additional participants recruited on the Friday mornings when they manned the food stand. They would hand out flyers and ask them to call. So instead of a interview face-to-face or a focus group that we thought we could have in their community, in their community room, instead, we were doing phone interviews. So we collected a total of 49 surveys, open-ended and quantitative. These are just pictures because I'm qualitative. Here's the Alexandra, here's the Alms. And they started to set up food gardens in the summer around those buildings. So across the street from the Alexandra, there's a big sign, it's a laundromat, but there's all kinds of grass in front of it. So they started planting gardens, which was great, and it got the community involved. You know, but gardens go away in the winter time, which is when, you know, the height of COVID was happening in Cincinnati. And so people were literally afraid to leave their houses. They were handing out, they had got volunteers to go to these apartment buildings. The people would hand them their lists of groceries that they wanted, and then they were getting volunteers to bring it back. So that was the kind of you know, their band-aid over what was happening at the time. So when we analyzed the data, our population primarily African American. The average age was 62. The range was 55 to 87. We asked people how long they had lived in the neighborhood. So the average was 21, but there was a range of 1 to 48 years. And it was 3/4 female, which is usual for older adults and older adults who are disabled. We also use the USDA Food Insecurity survey module that asks people a series of 6 questions and then gives you a score. So 65% of the population that we surveyed had low to very low food security, and 35 had food secure. So that meant that food wasn't lasting, they couldn't afford balanced meals, they were eating less due to not having enough money, and they were skipping meals, you know, just because of money. So the last 3 questions really are looking at, do you have the money to pay for food to last you through the month? What we came to the conclusion was, obviously 65% of surveyed older adults are food insecure, and their major barriers were transportation, a closer grocery store, the cost, and insufficient knowledge of healthy cooking. So what we asked, in addition to all the questions about food and grocery shopping and health, we also asked them if they would be interested in participating in a community academic partnership advisory board. And out of the 49 people that we asked, 31 of them wanted to be on the committee. So this now has become more of a community-based participatory project, because they're going to help decide how we're going to do this intervention, who's going to be involved, who's going to have ownership over the project, and so forth. So we just talked to an organization called Le Soup, which is on Whiteboard, I believe, at the end of Walnut Hills. We're at East Walnut Hills. And when they first met, they discussed these possible interventions to test models for healthy foods. And so when they discussed it, you know, they decided, yes, we're going to form this combined community academic partnership. We're going to make decisions together about what happens in our community. So their primary need obviously was groceries, and their secondary need was education for healthy meals. So we just met with Le Soup yesterday, and they are an organization that takes food that would normally just be thrown away and makes meals out of them. They freeze them or deliver them, or people come in and get them. So we are doing possibly a pilot program. The UC medical students during the pandemic were going and volunteering to do some of these things with older adults, and partner with Le Soup to provide a subsidized food delivery service, but also a healthy cooking curriculum. So that is where we are at today.